Hey guys, Don here. Welcome to Podiatry Practice Mastery, where I'm trying to help you get your practice to the $1 million mark and beyond. This is what I call the $1 million minute. It's basically the things that have to be done on a daily basis, and kind of in what I'm just sharing what's working for me in my practice. You might have a different type of practice, but this is kind of what's working. So what didn't work today is Morali, my scribe, had some computer issues, so he was unable to log into Athena. So I was kind of all by my lonesome today, and it just really made me value him much, much more, having him help me. And what happened is I just had to multitask. I had to do my notes. I couldn't really connect with the patients. Some of the notes were a little bit complex. So what I ended up doing, which kind of worked out, is I almost did like dictation. So I've never dictated before. I guess I dictated op notes, but I've never dictated. But I dictated to him what needed to be done for the notes for those patients, so he'll go back in afterwards when he can log in and do it. So that's the benefit to it. The bad thing is I probably missed some things because I wasn't totally present and I was kind of a little distracted. So another kind of reason where when you get to a certain level, I think everyone should have a scribe, whether it be an in-person scribe or a scribe that's helping you virtually. Mine's a virtual one, but having that extra hand can really help you produce more. Okay, so the patients for the day. This was a patient. I tend to have set treatment protocols for first and second visit. So a lot of times you're going to hear me talk about like nail fungus 1 and nail fungus 2, or plantar fascia 1, plantar fascia 2, or Achilles 1 and Achilles 2. But really most of the musculoskeletal are really the same. They're all based on my treatment sheets. So if you don't have those, you can go to patientpresentations.com and you can just get my presentations, and on the top of each of those presentations there's a treatment sheet that you can look at. So for plantar fasciitis 1, basically what that is I do x-rays, I watch them walk, they do my called the Pelto special, which is the night splint foam rolling morning stretch, and then they're usually getting meloxicam. So this patient, and they usually come in 3 weeks. And then at the next visit, then I usually do the ultrasound. So they get like the plantar fasciitis 1. And so I'll see him, and I'll probably measure the fascia and probably recommend shockwave at the next visit. Other patient was a patient I'm dealing with an ulcer. I debrided the ulcer, got x-rays just to make sure there was no osteo, and he'll do a 4-week follow-up for that. Another patient was a partial nail avulsion. I like to be clear. In the past, everything I used to do was a IND, and now I kind of make a distinction between a partial nail avulsion and an IND. I know it seems like something simple, but if there's no infection, I tend to do a partial nail avulsion. That's why I have it documented, because there's no infection. When there is infection or pus or redness, then I'll do an IND. IND does reimburse more, but I always like to be consistent with what my notes show. Another new patient that came in actually came in for right big toe pain, had a porokeratoma. And we talked a lot about posture. We talked about how their foot landed. They did have a cavus type of a foot that caused the porokeratoma on the lateral aspect of the foot. And I talked about bringing the ground up in posture, and then they decided to do an orthotic because of that. And just so you know, kind of in Massachusetts, orthotics are never covered by insurance, so it's a little bit harder. I always joke, if you're in an area more privileged than I am, where orthotics are covered, it's easy to give away something for free, but it's hard. You have to get much better when insurance doesn't cover them. Another patient that came in for a matrixectomy, did that. And then for this one, I'm not doing a follow-up. So we've been talking about how to reduce low-level follow-ups, like this partial nail avulsions, this matrix. This one specifically, they're not coming back, and I just give them full access to me if they need me. But it's a way to reduce lower-level visits, increase higher-level visits. Another patient that came in for fungal nail visit 2. What that means, the second visit is usually where I go over the nail sample results, and I make all the recommendations, where they're usually getting usually it's oral for me. They're getting an oral medication, they're getting the UV light, the biotin, and then the shoe spray. So that's kind of like my visit number 2 for nail fungus. Another patient that came in for a bunion, she was referred over from a chiropractor, and she had flat feet and bunions, and we kind of got in the topic of anatomic shoes. The way I kind of recommend it is I recommend anatomic shoes first, and then next would be like correct toes or toe spacers. I find toe spacers are a little bit harder to be consistent with, and she had more like the pronation, and I kind of showed her on her foot that as she pronated down, it kind of caused her bunion to go in, and that's how she was able to make the determination to do an orthotic. So that was my orthotic 2, and so that's what kind of my goal is for the day, is to get 2 orthotics. So that was 2 orthotics that day. Another patient came in for bilateral plantar fasciitis. They did EPAT number 2. And then there was another patient that came in with some sesamoid pain, and very similar treatment for all musculoskeletal things. So I got an x-ray. They're going to offload it. They already have a walking boot, so I didn't have to give them that, and I'll do an ultrasound in a few weeks when they come back. Another patient came in for Q10s number 1 bilaterally. Pretty much all my Q10s are bilaterally, but did Q10s. I'm having decent success with that. The hardest part is getting insurance to cover it, so I have basically one staff that only does that, so it takes her a lot of time. Another patient came in for wart treatment for cantharidin. Another patient that came in for talonavicular arthritis, and we talked about reducing the movement either with a orthotic or with a meso brace, which is kind of a midfoot gauntlet type of a brace, or talked about surgery, but she's going to think about those options. Another patient that was here for plantar heel pain with shockwave. Another patient with shockwave follow-up. So usually I see patients at 6 weeks for follow-up for traditional soft tissue. And then sometimes for bony issues, I'll see them a lot, or nerve issues, I'll see them in 12 weeks. And the main reason is because the like insertional Achilles tendonitis or the like neuromas or things like that, they just take a little bit longer, I think, for the shockwave to work. So she was about 50% better. I'm going to see her back in 3 months. And then the other patient here was a routine patient that had a hammer toe that was bothering him, and he was wearing an AFO. And so we kind of trimmed down the hammer toe callus and gave him kind of some shoe recommendations. And I gave him a new prescription for an AFO. And so his AFOs, I couldn't do them because I have to send them to Hanger. There's a kind of a carve out here in Massachusetts where I have to send it to Hanger. Another patient that came in that was an MRI follow-up, kind of a challenging case. She had overload to the second metatarsal with bone marrow edema in there. And she had kind of a small neuroma in the second intermetatarsal space. So kind of a challenging patient. She has some gait abnormalities due to a back issue, and she had already seen a neurologist. She's very frustrated. She was crying. It's a difficult time. I do not typically do injections to the second MPJ. I've had some kind of toe issues after that. But in her specific case, I did talk to her extensively about how this could cause a hammer toe, could cause weakening in the joint in that region, but she wanted a cortisone, so I did a cortisone in the second MPJ and also the kind of the neuroma web space area, intermetatarsal space, and then I'm going to see her back in 2 months, and then at that time we'll possibly do shockwave. Just kind of a challenging case because she's walking more on the front of her foot due to a back injury and kind of a foot drop, so I also recommend an AFO, and I'm going to send her to get that AFO because I think that's going to be helpful regardless. Another patient for a fracture follow-up at 4 weeks out. She had a 5th met fracture, and I typically try to reduce the fracture when I do a fracture code. I try to reduce the follow-ups to 1 if I can. So this was 1, and then I don't need to see her back anymore. Another patient that came in has kind of dorsal lateral foot pain. She had already done 6 sessions of shockwave. This is her second round, so she did 1 round, and this was the second round, and she still was feeling some pain, so I ordered an MRI for her. And then the last patient of the day was a bilateral matrix. So anyway, that's kind of the day. It was a little bit harder without having Morali, but it all kind of worked out. I've been listening to a new podcast. I don't know if you guys like podcasts, but it's kind of some neat ideas. His name is Alex Hamosi. He talks about the game, and he talked about a couple of things I want to highlight. One is the idea of why an associate, I guess I'm just applying it to podiatry here, why an associate gets paid less than the owner. And he talked about a neat idea. It's all about risk. So if you go out and you can just start your own practice, you're tending to make more because you're the owner and you take more of the risk. If you are just an associate, you're not really taking the risk. But the problem, he said, and this is something that's interesting, and this is something for all of us, even the ones that are starting out, like if you can't handle the downside, it's really hard to assimilate risk into your life. And what that means is if you are living, let's say, as a doctor, meaning spending a whole bunch of money, you spend what you earn. You have no savings. You have nothing to prepare yourself to be able to buy your own practice or start your own practice. You're just kind of strapped for money. And that's the challenge where a lot of the kids come out of school is they have this huge debt and they don't have any savings, and they're in a position where they kind of have to be associates and they can't start out on their own unless they just go more into debt with a loan. But he recommends kind of trying to reduce the downside, meaning save up as much as you can, kind of live as frugally as you can, and then starting your own, so you take more risk on, and you'll have more benefit. And I think this is a good point for a lot of us as doctors, just to try to live below our means, and that way you can take risks. What does that mean? What are some of the risks, though, even in my practice? Or you can buy new technology, like you can buy the Shockwave, or you can buy what other things that are going to produce you more revenue. You can buy these revenue streams. You can set up like some type of a surgical suite if you want to do in-office surgery and stuff like that. So, but you have to have the cash available to do that. So that was kind of one tip that he recommended. And the other thing that he kind of recommended is kind of simplifying what we say. And I kind of like this idea because he does a lot of sales training, and I know no one likes to think of us as salespeople, right? Oh, we're podiatrists, we're doctors. Yes, but we have to be able to explain things. And there's a website called Hemingway, and that's a way you can simplify what you say and kind of how it's written. And he recommends a 3rd grade level, reading level, and that's really low. But the rationale is if you can't simply explain what you're doing and what you're recommending for the patient, they're many times not going to understand it, and because of confusion, they're not going to take your recommendations. So one easy way of doing that is kind of writing out what you recommend and how you explain things, and then keeping it simple and using analogies. Okay, so some of the best people that explain things, and as you visit and shadow other doctors, you're going to see that they tend to use analogies to explain things. We've heard this before, using the analogy of like glasses as an analogy to an orthotic. So taking something they can't understand and making it like something they can understand. An analogy that I use quite a bit with Shockwave is I say a Shockwave is kind of like core aeration. It makes little holes and it lets the nutrients go in. So basically you're injuring it and you're bringing your own blood flow, whereas an amniotic stem cell injection or amnio injection is usually kind of like taking fertilizer, someone else's fertilizer, and putting it on your lawn to help it grow. So using analogies so you can equate something that they're not equated with to something you are equated with. So I would recommend whenever you're explaining things, or at least the first couple of visits, trying to take something that's unfamiliar and making it more familiar, and then simplifying what you're saying, because many times we use technical language, doctor language, and they just don't understand it. And because of that, they're not taking our recommendations. So anyway, those are kind of the thoughts today. Let me know how your practice is. If you have any questions, shoot me an email, don@podiatrypracticemastery.com. If you like this, tell me as well. If you don't like it, tell me as well, and I'll stop this format. Okay, thanks.